Welcome to this introduction to sickle cell disease. To many people, the term sickle cell disease is synonymous with pain, and indeed this remains a condition characterized by repeated episodes of vaso-occlusion, which block the circulation in small blood vessels, causing ischemia and tissue infarction. The body's response to acute insult is pain, in hopes of triggering a move away from the painful stimulus. Sadly, with sickle cell disease, the vaso-occlusion is not relieved by any movement, and the pain carries on. Despite the fact that the molecular basis for sickle cell disease was worked out more than 110 years ago, we are still in a position where getting on top of pain control is more challenging than it should be. Equally important is the fact that sickle cell disease is more than just pain, and as patients live with this condition, they accumulate chronic complications in almost every organ of the body. Looking after people living with sickle cell disease includes the management of life-threatening episodes, pain control, and the prevention of long-term complications. Let us look at the things that people living with sickle cell disease are saying and the questions they're asking to get a better idea of how this condition affects them. Things like, will I be able to have a family? How do I tell a potential partner I want them to get tested for their genotype before we take the relationship further? I can't plan my life properly. I keep having to cancel outings with friends, asking for extensions for deadlines. My sickle cell disease makes me feel alone and isolated. No one really understands what it's like. I know there are new medications coming along, but can I take the risk to try them? What I might lose is more important to me than what I could gain. Every year, an estimated 7.9 million children, or 6% of total births worldwide, are born with a serious birth defect of genetic origin. 3.3 million children under 5 years of age die from birth defects each year. 25% of these conditions are comprised of 5 diseases, with number 3 being hemoglobinopathy disorders, namely thalassemia and sickle cell disease. This amounts to 308,000 births per year. Many people are familiar with maps such as these, where we can see the distribution of thalassemia, sickle cell disease, and other hemoglobin variants across different countries of the world, and we know that their prevalence has been heavily influenced by the existence of malaria, and the fact that at a population level, the carrier state is protective against severe malaria infection. And this is the reason for these mutations to have spread in these parts of the world. It's of course important to realise that these disorders are no longer confined to the malaria endemic regions of sub-Saharan Africa, the Mediterranean and Southeast Asia, but due to population migrations have also become a public health problem in the United States and Northern Europe. The life expectancy of patients with sickle cell anemias has doubled since 1970. Data from the Dallas newborn cohort showed that most children with hemoglobin SS and nearly all children with milder forms of sickle cell disease now live to become adults. The incidence of death and pattern of mortality has changed over the duration of the cohort, and sepsis is no longer the leading cause of death. Sickle cell disease has now evolved into a degenerative disease with significant morbidity due to end organ damage. But mortality remains a significant problem, with children and young adults still dying from this condition. Data from King's College shows that the estimated median survival for hemoglobin SS or S-beta-0 thalassemia is of 67 years, and for hemoglobin SC, 82 years. For the more severe genotypes, this is 20 years life expectancy less than the general population. There are a number of different genotypes which can cause sickle cell disease. The 4 more common are illustrated here. There's hemoglobin SS sickle cell disease, hemoglobin SC, hemoglobin S-beta-0 thalassemia, and hemoglobin S-beta plus thalassemia. What you can see on this slide is the types of hemoglobin that you expect to see in red blood cells. In hemoglobin SS, you would typically see just hemoglobin S, which is 2 alphas and 2 S. In hemoglobin SC, you can see hemoglobin S, hemoglobin C, and a combination, 2 alphas, 1 S and 1 C. In hemoglobin S-beta-0 thalassemia, you would commonly see just the hemoglobin S. And in hemoglobin S-beta plus thalassemia, you would expect to see a little bit of hemoglobin A. Having said that, all types of sickle cell disease tend to be associated with a small rise in hemoglobin F, which is 2 alphas and 2 gammas, and these have not been put on this slide. All in all, the clinical course of sickle cell disease will be dictated by the genotype, the haplotype, co-inheritance of alpha thalassemia, and other genetic and environmental factors. In this electron microscopy pictures of red cells, you can see a normal red blood cell with its characteristic donut-like shape, biconcave disc, and an irreversibly sickled cell. What's important to remember is that sickle cells will go in and out of a normal shape to a sickle cell and back to a normal shape and back to a sickle cell as oxygen levels go up and down through circulation. After some time, the damage is so great that the cell is irreversibly sickled and cannot change back to a normal shape. The pathophysiology of sickle cell anemia is very dependent on oxygen tension. At low oxygen tensions, the hemoglobin S polymerizes, and this stretches the cell and turns it into the sickle cell. The change in shape of the red cell, the constant stretching and unstretching of the cell, leads to intravascular hemolysis. But there is also recognition of the sickled cells by macrophages in the spleen, which leads to extravascular hemolysis. All in all, there is anemia and a drive to the bone marrow to produce more red blood cells. These sickle cells also cause vaso-occlusion, which means that the red cells are sequestered in capillaries and obstruct the flow of blood, leading to tissue ischemia, long-term complications. The microvascular obstruction is a complex event, and we now understand that it involves more than just the sickled cells, but also white blood cells and their interaction with the endothelium, in particular through molecules called select. We will now look in more detail at the events that lead to the acute painful ischemic episodes and the chronic progressive organ damage. The small vessel obstruction which occurs is one of the two main pathophysiological processes in sickle cell disease. This vaso-occlusion is the one that causes the acute pain episodes due to bone infarction. But it's also responsible for silent strokes in the brain, glomerulopathy and papillary necrosis in the kidney, sequestration crisis in the liver and the spleen, acute chest syndrome, and acute multi-organ failure. On the other hand, the large vessel obstruction follows the chronic hemolysis. Patients with a low hemoglobin and a high hemolytic rate seem to form a subtype related to large vessel obstruction caused by endothelial dysfunction and proliferative changes in the intima and smooth muscle of the blood vessels. These changes underlie the infarctive stroke and pulmonary hypertension, but also intramyocardial arteriosclerosis, left ventricular fibrosis and failure, pulmonary artery thrombosis and narrowing with pulmonary hypertension and cor pulmonale, and the ischemic and hemorrhagic strokes. We tend to divide the complications of sickle cell disease in adults into those that are acute, which as I've said relates mainly to the vaso-occlusion, and those that are chronic due to damage to blood vessels and organs. Acute complications include pavement crises, acute chest syndrome, infection, acute anemia, priapism, stroke, multi-organ failure, and acute cholecystitis. The chronic complications include chronic pain, avascular necrosis, pulmonary hypertension, chronic sickle lung disease, proteinuria and renal failure, retinopathy, chronic cholecystitis, sickle hepatopathy, neurological and neurocognitive impairment, and infection due to hyposplenism and immunodeficiency. And of course, there are also the acute on chronic complications. In this slide, you can see the outcome of sickle cell anemia from a 4-decade observational study of 1,056 patients. This was a prospective cohort observed for more than 40 years that was started in 1959 and therefore totals 1,427 person years. The main takeaway message is that all patients eventually had some form of organ damage. Essentially, they also found that the presence of one complication significantly increased the risk of another complication. This emphasizes the need for monitoring, early detection, and early intervention to minimize organ damage. One way to summarize the aim of treatment when you're looking after patients with sickle cell disease is that we want them to get old. This is something that is actually very helpful to say to the patients as it projects them into the future and emphasizes that their clinical team are there to try and improve their quantity and quality of life. To achieve this, it's important to start early, to carry out a lot of patient education in a way that is meaningful to the patients. The patients need to be engaged, but in fact also the medical team needs to be engaged because this can only be achieved as a real partnership between the people living with sickle cell disease, their family and carers, and the medical team looking after them. It's not possible in this short introductory lecture to go into a lot of detail about the management of sickle cell disease, but a few key features will be highlighted. When dealing with painful vaso-occlusive crises, it's important to educate the patients about how to avoid precipitating factors like the cold, dehydration, hypoxia, and infection. Non-medical management is important, warming up, drinking fluids, resting, staying indoors, but also learning about analgesia, what works for them, how, when should they be increasing their analgesia or changing the type that they're using. It's important that they know when to contact the medical team and how to do so. And then there are standards for the management in hospital, how quickly analgesia is given, in what form, hydrating the patients and giving oxygen. The prevention of complications is also very important. People living with sickle cell disease are hyposplenic usually by the age of 3, and oral penicillin to prevent infections is important, as is vaccination against pneumococcus, Haemophilus influenza, and meningitis. In children, monitoring of the transcranial Doppler is a very good way of picking up the children who are at high risk of developing strokes and who need to go on to preventive red cell exchange transfusions. We monitor the protein-creatinine ratio by doing a yearly urine test in order to pick up any glomerular damage and the finding of microalbuminuria in the urine. And then patients are invited to retinal screening with ophthalmology every year or couple of years in order to detect early changes of retinal proliferation. Blood transfusions are an important part of managing sickle cell disease. Sometimes these are used for emergencies, such as an acute chest syndrome or a stroke. It can also be given when there's a significant drop in steady state, so a drop of more than 20 grams per litre from baseline. It's important to remember that a lot of people living with sickle cell disease already run a slightly lower hemoglobin. It's important not to transfuse people to a same level of hemoglobin as you would somebody who doesn't have sickle cell disease, because firstly, hemoglobin S gives off oxygen more quickly than hemoglobin A, and secondly, there is already a hypercoagulable state, and therefore patients should not be rendered hyperviscous from too much transfusion. Transfusions are also used before major surgery, and these would be red cell exchange transfusions, so that the level of hemoglobin S is less than 30%. And then finally, it's important to remember that transfusions should be used only in patients in whom they are necessary, and that's because 10 to 30% of patients develop red cell alloimmunization. This will hopefully be reduced as we carry out extended phenotyping and eventually genotyping, and the blood is better and better matched. The bottom line here is that you should always discuss with a consultant before carrying out a blood transfusion in a patient with sickle cell disease. What about cure in sickle cell disease? At the moment, the only curative option is bone marrow transplantation, which is available in the United Kingdom for children and some adults, or gene therapy, which is still undergoing clinical trials. The mainstay of treatment, in addition to the monitoring we've discussed, is hydroxycarbamide. There are some recent British Society of Haematology guidelines on the use of hydroxycarbamide in adults and children with sickle cell disease, and this should be offered to most people who have sickle cell disease. Hydroxycarbamide works in a number of different mechanisms, but one of the main ones of which it has a beneficial effect is by increasing the level of hemoglobin F. This protects against long-term complications of sickle cell disease. Hydroxycarbamide needs to be given at the maximum tolerated dose in order to have its best effect. This will differ between patients. In conclusion, I think we can finish with Nelson Mandela's quote that education is the most powerful weapon we can use to change the world. In our case, this is education of the patients, education of the medical team, so that we can learn how to look after people living with sickle cell disease in a way that will make a difference to them every day.